Yeah, so I'll be sharing some of the iris challenges that we face in a so-called routine cataract surgery, and I acknowledge the support of Dr. Lajja Shastri in making this presentation. Can I have my slides on, please? We do receive research grant support from Alcon Laboratories. So this was a 65-year-old male on oral tamsulosin for benign prostatic hyperplasia, which is very, very common in this age group. And keep noticing here, first of all, my parameters are not very high anyway. So it's 40 IOP and about 20 cc flow rate. But keep looking at the area of the chopper. Slowly you'll start finding that the shape of the pupil is changing a little bit. So instead of round, it started to ovalize a little bit. And it's tending, that ovalization is tending to go towards the side port, which means that this iris is now showing tendency of prolapsing or becoming floppy, which can occur very commonly in patients with tamsulosin. So often we hear the dictum that once the iris comes, it will keep coming on right through the surgery. But I think if we detect it early, we can really help to prevent this from going worse. So once I detected that this problem has started to occur, notice I've gone back to now foot position 0. From foot position 1, I've gone to foot position 0. And I've lowered my IOP from 40 to 30, which means I've lowered my parameters even further down because I don't want excessive fluid to be going behind. So I've lowered it from 40 to 30, just repositioning the fragments in an appropriate position. And then when I go back to foot position 1, the iris falls back. And now all through the surgery, the iris will not misbehave and will not come back to my side port incision. So if you recognize it early and if you change your parameters appropriately, you can prevent an actually full-blown IFIS from occurring where it could have occurred. And the reason why IFIS typically occurs is when there is a pressure imbalance gradient between the fluid in front of the iris and behind the iris. So quite often the mental thing that we have, the pupil is small, increase the bottle height. In fact, do the opposite. If you pump in more fluid, it will actually go behind the iris more and it will push the iris more towards the incisions or towards the endothelium. So detect the warning signs early, and whenever, in whatever situation, PCR, iris, whenever you're in trouble, instead of raising your parameters, just lower your parameters. And this also quite often occurs in situations where there are what we call as corticocapsular adhesions, because these sort of are these are not the this is not the cortical opacity of the cortical cataract. They are really adherent to the capsule, and therefore when you do a hydrodissection, quite often those cortical capsular adhesions do not allow that fluid to pass through, and therefore there's an incomplete hydrodissection. And since the nucleus doesn't rotate, we end up over hydrodissecting, and sometimes that leads to iris prolapse as well. So this was a 68-year-old female, diabetic, hypertensive, obese, heavy breather, but the cataract was reasonably okay. So you can see it's a smallish kind of a rhexis, and we are doing hydrodissection, and we want to see the wave passing from one side to the other, which was seen in this case. But the surgeon felt maybe this patient requires multiple injections or multiple quadrants of hydrodissection. And if you notice there, that small little thing, just here, brushing of the iris, even that small little brushing of the iris can be detrimental, and over injection where probably the hydrodissection was already done enough has led to this now iris coming to the main port. Having seen that the iris is coming to the main port, the second mistake that I tend to do is over-inject further more viscoelastics, and then I use the side port to try and use this metal instrument to bring it in. Now typically this leads to a lot of pigment dispersion. But as I've already over-injected the eye with viscoelastic, I'm struggling to get the phaco probe in, and the iris is showing again signs of coming out. The next mistake I make is injecting viscoelastic to the same incision. If you do that, it will constantly keep coming out further and further. And eventually I had to sort of give up. So now what I'm doing is I'm coming from the side port and injecting dispersive viscoelastic over the area where the iris is coming from. And here I suggest dispersive viscoelastic because it will stay there, unlike a cohesive viscoelastic, which will immediately come out as a bolus. And so therefore I've tried to equalize the pressure. I put now more pressure in front of the iris than from what is coming from behind the iris, so the iris should stay down. And then the entire surgery is done under very low parameters. So I'm very conscious now that I had a mishap early on. I don't want it to continue to happen, and therefore I'm using an intraocular pressure of only 20, which is equivalent to a bottle height of 37 centimeters. And I'm making sure that my phaco probe all through the procedure remains in the center of the eye. So whatever movements that are being done will be done with my left hand. My right hand remains dead steady in the center, so that the fluidics work only in the central part, and there's very little chance of fluid going behind the iris and causing further turbulence. So equalizing the pressure in front and behind the iris is the key from preventing this from occurring again. And even if you see this before irrigation aspiration, just inject dispersive viscoelastic from the opposite incision, not from the same incision. That will help it to not only come inside but also fall back easily and nicely. So never reposit through the same incision, and use dispersive viscoelastics whenever possible. This is something that we often ignore, making the main incision, and particularly if you're not careful with very nice sharp blades, if you've ended up with a very short incision, and by short incision I mean the distance between the external incision and the internal incision, like in this case, is hardly 0.1, 0.2 millimeters. Ideally you want two-third distance, two-third of the length of your external incision. So if I have a 2.2 millimeter incision, I need at least a 1.8 millimeter distance between the external and the internal incision. And when the incision is very short and you overzealously do a hydrodissection, this is what typically commonly occurs. With a very short incision with excessive hydrodissection, the iris tends to prolapse. Here I'm trying to follow the principles of pushing it back, but I still forgot that after the iris went in, there was no need to redo the hydrodissection, and I undid whatever little gain that I had gained, and now this is not a very nice situation to have with these iris, sort of getting so battered. And this typically, like I said, occurs is with the short incision. If the pressure below the iris increases, it will immediately prolapse towards the incisions points. Having reposited the iris nicely, now I'm very conscious once again that this can occur at any point of time, and therefore, like in the previous case, we'll go ahead and do our entire surgery with a very low intraocular pressure, very low fluidics, 20 IOP and 20 cc flow rate, and an appropriate vacuum, and making sure that my right hand remains right stable in the center of this irregular but distorted pupil, and therefore further distortion or further prolapse of the iris doesn't occur. If you're not doing bimanual, I think these are the cases where you should do bimanual, because I don't want to use this main incision as much as possible so that the chamber doesn't collapse and the iris doesn't prolapse further. And this bimanual gives me good access all around by swiping my hands, and I can use the second hand to just retract the iris to see all the cortex is out. Fortunately, things went off well. The iris did not prolapse any further, and we went ahead with our plan A of doing a single piece IOL in the back. So incision is also something that is very, very important, and you can notice here, this is the length of the incision. So if you end up with a very short incision, it can lead to iris prolapse. Another example of the same, a very short incision, which means a very small distance between the external incision and the internal incision, and therefore once you overhydrate, the same situation can occur in such eyes as well. Always make sure in such eyes, when you are injecting the IOL, that your left hand stays on top of the IOL, because you want to avoid brushing and rubbing of the IOL also on the iris. And fortunately, the iris happens to be one of the most forgiving tissues. So if you have handled it reasonably well, they do quite well post-operatively. So I think pay attention to wound construction. Iris prolapses, if detected early, can be managed appropriately without further worsening intraoperatively or the iris constantly coming to your incisions. Whenever in doubt, or whenever the iris shows the signs of floppiness, lower your parameters from whatever your existing parameters are. So even if you are already using low, make it lower. And of course, post-operatively, these patients are more likely to require anti-inflammatory therapy, particularly NSAID eye drops, as they are at a high chance of developing cystoid macular edema post-operatively. So thank you so much once again for the patient listening.
I think these iris is coming to the side port and the main incision is not that rare. More of us see that, like we see desmoid detachments around the small pores and main incision. So we need to be extra vigilant about it. But as far as the floppy iris is concerned, I think the pressure gradient theory is really very useful. Keep the pressure in front of the anterior to the iris more than the pressure because of the OVD or fluid behind the iris less. So that will prevent iris coming to the port, but also will prevent the floppiness. So phacoaspiration of the iris would be reduced. While I'm talking, I want Mohan Rajan to be ready with one tip of floppy iris on the mic, please. So that pressure gradient is very important to keep in mind. Low bottle height, adequate power, vacuum, and energy. So what, if you have to name one pearl for floppy iris, what would you say, sir?
I think the floppy iris, the history is very important, sir. And also, what I do is, it is better to be safe than sorry. Right in the beginning of the surgery, because I know it's going to become lesser and lesser, so I use iris retractor straight away. Whether a Mulligan ring or a iris hook or a BX ring, whatever it is, right in the beginning of the surgery, I do it. Because halfway through, it's very difficult to put. So my take-home message for everybody is that if the pupil is about 6 millimeter or less than that, that's going to become 3 millimeter during the surgery. Whatever you do. So right in the beginning of the surgery, you make a decision and do it. That's my message, sir.
Thank you. Thank you. Useful. Now, any comments on it?
If I may, sir, I completely agree with the pressure differential that, keep the eye soft before you do a hydrodissection for that matter. Once you complete your rexis, there's some visco which has come out. Don't refill the eye with viscoelastic. Do the procedures with the eye soft. I usually tell in a hospital, approach it like a corneal tear. We don't keep refilling the eye with viscoelastic so that the iris will keep coming out. But once the iris is inside, and if your side port is not leaky, if your side port is leaky, make a fresh side port. That's also very, very important. Even if you go with a phaco probe with a slightly higher IOP or bottle height, of course, Shail is very comfortable doing it at 20, but if you're hesitant to do it at 20, once you're inside, it just pushes the iris down. It only if there is a leaky wound in the main wound or the side port is it going to push the iris back towards the side port and make it more floppy again. But if there is no wound leak, you would still be all right even if you're using a slightly higher IOP.
Thank you. Yes, Rashad, you
I think Viscoat really helps. I mean, even for dilation, just putting a layer of Viscoat over the iris, not necessarily to protect the endothelium, and because it aspirates so slowly, it just pushes the iris back and it just keeps it there much more securely.